you all for coming on a weekday night. We appreciate you making the time to come and see us for what we're calling Getting to Affordable Universal Health Care. Health care has certainly become a more important issue over time, and it stands to probably become even more important in the foreseeable future. It's also a complicated problem, partly because we're not just talking about healthcare insurance coverage, but availability of actual healthcare services.
You speak louder and bring the microphone closer. Yeah.
And also things like co-pays and other expenses that you might have to incur before getting the health care, like deductibles. So, and not to leave out the cost of pharmaceutical drugs. And to complicate things further, on the national level, there are now at least 13 healthcare insurance bills that have been introduced last year and this year in Congress. And many of these bills will provide coverage options alongside existing medical insurance plans. 4 of those bills have words Medicare for all or Medicare for America in their titles, and they propose a single public insurance plan that would replace most private health insurance plans. These bills differ in who can be covered under the proposed healthcare insurance plan, what sorts of services are covered, and how people pay for insurance coverage and healthcare services. There are also differences in subsidies and in cost containment strategies. The bills can be grouped into 3 basic approaches to providing health insurance and services. First approach, more private health care insurance regulation, enhancing the Affordable Care Act. Second, a choice of public health care insurance options alongside existing private plans. Things like including Medicare-like plans and Medicare and Medicaid buy-ins. And lastly, a single-payer public plan. The Commonwealth Fund provided some online comparison. There's a URL for that. They call it the many varieties of universal coverage. The Kaiser Family Foundation has also issued some reports and issued briefs starting in October 2018 and ongoing. So let me introduce the panel members. Directly on my right is William Thayer. He's a physician who has experience in many sectors of healthcare. He's a graduate of Michigan State University, College of Human Medicine, did his residency at the University of Michigan. Also received an MPH in Healthcare Administration and Epidemiology. He's operated a private primary care practice, been the medical director of rural public health programs, and directed epidemiology programs at a major U.S. corporation where he also provided medical consultation to their healthcare benefits programs, and was a developer and medical director of a healthcare management company before his retirement. He has seen the fragmented, expensive, and highly variable care provided in the United States, and is committed to the development of a national health program based on HR 676. Next to William Thayer is Kathy Stead, who's a senior policy advisor at the Robert Wood Johnson Foundation. She works on healthcare issues, mostly those related to health insurance costs and access to care. Her work in the policy unit, she seeks to inform policy discussions at the federal and state level by making data and analysis widely available. She's particularly interested in sources of data that can have the potential to inform policy available to researchers and the public sector. She joined the Robert Wood Johnson Foundation in 2011. Prior to that, she was director of the Center for Health Statistics in the New Jersey Department of Health, where she focused on analysis and dissemination of major data sets, including vital statistics, hospital discharge data, and behavioral risk factor surveillance. Next to Catherine is Joel Cantor. Joel is a distinguished professor of public policy and the founding director of the Center for State Health Policy at Rutgers University in New Brunswick. Dr. Cantor teaches healthcare policy and mentors graduate students at the Rutgers Edward J. Blaustein School of Planning and Public Policy. He's a widely published scholar on effects of health insurance regulatory policy in New Jersey and nationally under the Affordable Care Act. He also leads research on innovative health service delivery and policy strategies for the Medicaid program. He serves frequently as an advisor on health policy matters to New Jersey state government, including recently as a member of Governor-elect Phil Murphy's healthcare transition team. He also currently serves on the New Jersey State Health Benefit Program Quality and Value Task Force. So what I'm going to do from here on is I have a list of 6 questions, and I'm going to pose them one at a time to each of the speakers. I'm going to give each speaker about 4 minutes to try to answer the question so that we can leave enough time for some questions from the audience. So the first question, what are the important risks inherent in the current healthcare insurance coverage environment presently and in the next 10 to 20 years? Please quantify risks when possible.
Thank you for all coming, first of all, and it's good to see people interested in healthcare debate. The obvious risk in the next 10 or 20 years is essentially the cost of healthcare. That's the overwhelming risk in the United States. The CBO estimate is this is going to increase to 5.5%, somewhere around that per year. It's typical 2% premium over the GDP. So we're going to see increasing costs in the system that keeps shutting more low-income people out of the system, even with health insurance. That means also on the top end, health insurance becomes much more expensive. And as a social issue, it starts to compete with other priorities like education, infrastructure, defense, even, and local and state government expenditures. So we have a major issue in the cost area. And we know through current research, really going back to some of the original work by Uwe Reinhardt, that the reason that healthcare is so expensive in this country is the price. As he said, it's the price stupid. We're simply paying too much for the services we get. It's not that we use more services than anyone else. And in many areas, we actually use fewer services. In a few areas, we use more. But overall, we're not using more services. We have a very expensive system in which prices are much higher than other developed countries. So the real issue is, how are we going to deal with that? And I really think for myself, I use 4 different factors to judge any kind of policy that's going to be implemented in the country. First of all, does it provide universal coverage? I think we all understand that this is not just a moral obligation, but it's really an obligation to provide care. As physicians, we understand that continuous care is an important issue, especially in the era of chronic disease and chronic disease management, where that's the overwhelming majority of healthcare costs. And secondly, I believe that universal care is actually a major contributor to lower costs in many countries. As a kind of natural experiment, those countries with universal care are all less expensive than the major country that does not have universal care, which is the United States. So healthcare, universal care is a moral issue, it's a medical care issue, and it's a cost issue. All of the other systems also have a way of dealing with prices and spending control. So any plan that's really going to deal with the cost of medical care and access to medical care also has to deal with prices and spending control. Almost all other systems have some way of doing that, either through budgeting, national negotiation for prices with providers, or very controlled methods of competition amongst providers. So unless a program really, again, focuses on that area, we're not going to make progress in price control. A third major area is standardization of coverage and plan benefits. Every other country has some level of standardization of benefit plans and coverages. We have literally hundreds of health plans in this country, which unfortunately converge on the physician and providers. We're the point at which we see all of those every day in our practices. And so that makes for a very complex and expensive system of overhead. And one more thing, they all fund their programs through, primarily through social insurance. Most countries that have lower healthcare costs than ours use a social insurance system to provide funding either directly or through premium support. So that means they have a fair system of progressive taxation and assessment to equalize the burden regardless of income. So those are the things we need to look at to really deal with the next 10 to 20 years of the judge programs.
Thanks. So that was wonderful. I share the facts, which is something these days we can't take for granted, that we all share the same facts. And I also share your observations about what's sort of driving our costs. And, we read the same literature, and it's prices. There's some other things there too. Thinking about the next 10 to 20 years. So I'm assuming the question is, what if we stay on the same path with a mostly private health insurance system? What is it going to look like 5, 10, 20 years ahead? And there's a few fundamental forces in play that will remain in play. So, and a lot of it's market-driven. So about half of Americans get their health insurance coverage from a job, their own job, a spouse's job, a parent's job, retirement coverage, and so forth. Just short of half of the population. So that's it's the biggest source of coverage. Well, that form of coverage is really driven by labor markets. So why do employers offer coverage? Because they need to attract and retain workers. And that means that in times like the present, where labor markets are very tight, employers have to offer decent coverage and they have to pay decent rates. So this is as good as it gets right now. But we are going to have another recession. It's inevitable. It may be soon. And then employers will do everything they can to weasel out of, this is a broad generalization, depends on which labor markets and so on, but on average, employers are going to start trying to pull back. So how do they do that? So fewer will offer, and right now and under the Affordable Care Act, large employers are required to offer and pay a certain amount, or they pay some penalties, but they'll find loopholes, and small employers will begin to drop coverage. Large employers will do everything they can to shift more costs to the workers in the form of higher premiums, employee share premiums, higher deductibles, higher co-pays, and so on. So as the labor market weakens, we're going to, that half of the population that gets their insurance through a job is going to feel more pain. The other part of a different market force is in play here, which plays into this issue of prices. So prices are the sort of rising prices, number one cause of rising healthcare costs. And there's a lot of movement across the country for healthcare providers driven by hospital systems to consolidate. By that I mean mergers, acquisitions, and truth in labeling. I work for Rutgers, and there's RWJ Barnabas Rutgers Health, and we're guilty as all of them in larger and larger health systems. Well, why do they do that? Because it gives them bargaining power against the insurers. And I think we're going to continue to see that kind of market consolidation. There's no appetite in this administration, or even the ones before, to do much antitrust enforcement, except in the most extreme cases like Pittsburgh. So we're going to continue to see prices increase. I've been saying since I got into this business a long time ago that at some point there's going to be a tipping point, and we're going to switch over to something Bill will like. That may have happened, but it hasn't happened yet. We're at about 18% of the gross domestic product. We're in the next decade or so, we'll hit 20% of every dollar earned in this country will go to pay for health care. We're not far from that now. So if you project that out 30, 40, 50 years, we're talking about half the GDP going to health care. At some point, it's not sustainable. I don't know where that point is. So anyway, just starting to put gasoline on the fire. But now I'll turn it over to Kathy.
Thank you. It's actually really hard to go last because it's hard to think of new things to say that haven't already been said. And I think one of the things that Joel said that I would pick up on is that, since the ACA, maybe one of the things that we saw was a pretty substantial decline in uninsurance and increase in the share of the population that was in Medicaid. So we had sort of a change in the payer mix. So we had more people in either Medicare or Medicaid. And what we started to see then is this growing differential in public-private health service prices, and particularly hospital prices, which is related to the consolidation and the kind of increased market power that a lot of systems had. And I think that's one of the things that's really heightened awareness of lately is this trend in commercially negotiated rates and hospital prices. And I think that in part it's a byproduct of the really tight labor market that we have, which is another thing that Joel mentioned, where employers want to offer really generous coverage. They want the must-have system in their network. They're willing to pay. And I think some of the things that we see happening is, which is a kind of an unfortunate byproduct perhaps of the kind of system we have, is that hospitals take extra revenue and use it to build new patient towers or other kinds of things, and then their cost structure increases, and then they go back to their employers or their customers and say that they need to cover their costs, and they can't cover their costs, because they have so much Medicaid, so much Medicare, losing money, they need more money. So I think that's one of the things that really drives healthcare spending that I think there is a lot of awareness of lately. And I actually do think that we're getting a little bit more open to the idea of some more muscular kind of antitrust activities. I'm certainly hearing a lot of talk about that lately, so we'll have to, kind of see where that goes. And I think the other side of that really acceptable to anybody right now. So I think it will be interesting to see what that translates into, but there's certainly some big parts and differences about what's the best way to remedy that. Other things I think to just watch if you're thinking about, just spinning out 10 or 20 years. I think one thing that's a really unaddressed issue is long-term care, which you probably know sort of got dropped out of the ACA because of the Plans Act, which was going to provide some long-term care coverage. It's a really big gap for a lot of people now. The private long-term care insurance market really is dysfunctional and doesn't work, and so you have many people spending down and going into Medicaid, which increases fiscal problems for states, and that is bad for families because they end up with no assets to leave to their heirs. So I think a lot of people are thinking about that as a problem that's only going to get worse as the population ages and savings rates are really low. And then another thing that I think is just inevitably going to shake everything up is this pipeline of very, very expensive therapies, which may be curative and maybe will be shown to have ROI and be, I'm sure a lot of them are amazing scientific advancements, but I think that they are going to really rock risk management in a lot of places, and I think that they're going to be very, very hard to handle, even for large self-insured employers. Once you start to have an increasing number of people with maybe claims of over $1 million, and I think that's something it's an inevitability, and it's not clear to me how we're going to handle that in the context of our current system.
Speaking of turn, but when we look at these sort of blockbuster breakthrough drugs and the like, the only thing stopping the manufacturers from charging an infinite amount is embarrassment. If something saves lives or has a significant improvement in health, under insurance contracts it has to be covered. And because of patent law, there's only one seller, so it's monopoly. It may be monopoly for something that only a few 100,000 people or fewer need, but they can charge $100,000, $1 million a year in some harm. And there's just a lot more in the budget itself than they start.
What is it? Okay, the pros and cons. What are the pros and cons of each of the three basic approaches and important variations of the bills within each approach? Remember that healthcare includes prescription drugs, and then we forget. But yes, so there's a bunch of proposals to sort of reform or enhance or improve or recreate the way that we provide health insurance to the population. And I guess the most incremental bucket are things that really build on the ACA, maybe add reinsurance, change the subsidy structure, make the ACA kind of fortified and work better. Then there's a kind of a big middle category, which is a bunch of different kinds of public option type bills that many people call them Medicaid buy-ins or Medicare buy-ins, and most of them are not exactly that, but they're sort of buying into a plan where there's some rate setting at work and providers are being, accepting some kind of a benchmark rate that's pegged to Medicare or pegged to Medicaid, but that doesn't exactly mean those plans are exactly Medicare. Usually they actually have, I think, proposed that a little bit better benefits than Medicare. And the basic idea is you create some kind of a public option, meaning, both that it's open to the public, although there's different eligibility categories in some of these different plans, and then also that there is some sort of public sector leveraging being brought to bear on what providers can charge, and a similar kind of collective approach to negotiating for prescription drug prices. So, and then the third option is kind of a single payer option, which really, replaces all of the different sort of fragmented other kinds of health insurance that we have in the country with one plan. So this would be something analogous to the National Health Service or something where we have rate setting for providers, and we have single negotiation for prescription drugs, we have a national formulary, and we have one plan. So the pros and cons of each of those approaches. starting with the most incremental one, and some people might say that the pro and the con is that it's the most incremental. I mean, it would expand coverage, it would make coverage more affordable for some of the kind of notorious groups of people that are squeezed out, like people that are in the individual market that don't qualify for generous subsidies. It might help some of those people. It might make the individual market more attractive for that recession that Joel was talking about, and more employers would maybe stop offering coverage and people would migrate to the individual market. The cons are that it maintains our, heavily subsidized. I mean, the government spends like 45 cents of every healthy dollar. We don't really have a totally private system by any means, but it maintains that kind of fragmented patchwork of different programs, for better or for worse. And, it's an incremental change. The middle category, I think a lot of people would say, okay, first of all, I would also say, I personally think a lot of that middle category is kind of a ACA and steroids, because a lot of those public option plans are really built on the chassis of the individual market. And I actually think, the existence of that standardized individual market is a pretty big change. And it is a change that I think could allow us to ultimately have even broader coverage and be able to, have a little bit more public sector leverage and how much things cost. So I think that that sort of middle range of options, I think the big step forward there is an element of rate setting, and that's something that right now we have in Medicare. Obviously, that we have rate setting in Medicare, we have rate setting. Yeah. I mean, the government sets rates, and we have in Medicaid, states are basically, accepting bids from managed care organizations, but then sort of, setting rates. And then we have in the kind of the rest of our economy, we have insurance companies and providers negotiating, and that's where sort of a lot of the trouble is that a lot of those rates get pretty high. So this public option would try to create a plan that was available to other people, that are not in Medicare and not in Medicaid, that actually have providers accepting a rate of pay which is quite a bit below what they would accept otherwise for taking care of those people. So, first of all, that's going to be fought very, very hard. I mean, the pro is pretty clear. It's going to save money. I mean, healthcare will be cheaper. It's not going to become free, and no one's going to say it's going to be cheap, but it's going to be cheaper. The con is that it would be fought very, very hard by, the AMA and the AHA, and it would be a tussle. I think there's so much going on in this whole arena of poking at privately negotiated prices and trying to figure out ways to get them lower that nobody's going to be surprised. And, maybe we're going to see some more conciliatory behavior from hospitals worrying about the possibility of something like that. But I mean, I think the con is that it would be hard to get through, politically hard and disruptive. And the third option, Medicare for all, sort of a single payer system. I mean, I think there you have, you have simplicity. You have the fact that it's kind of the same for everybody. Everybody's going to have the same access. I mean, a lot of countries with centralized, like a single payer system do have kind of a private private insurance for people that want to spend more and get better access. You might not have that here, but in general, everybody will pretty much get the same thing. So there's the quality aspect, which is positive. I would assume if we collectively negotiated for drug prices, we might expect that drugs would cost less. Although, people aren't just going to sort of roll over and not fight these things. It won't be as easy as people might think. I mean, I think the con is you're giving even more sort of responsibility to the federal government for determining your access to health care, the quality of the health care, the availability of the health care, and that's a hard thing for people to give up. And I think the idea of getting rid of private insurance companies, I mean, everybody hates insurance companies. That's been true since there were insurance companies. Everybody step. And I don't think that's going to necessarily be better. And I think the other thing that just sort of needs to be said is that you end up with a system that's super affordable to individuals. It may end up being societally very, very, very expensive. So you have to think about, either no one's going to manage utilization and that's a problem, or somebody's got to manage utilization and that's a problem too. It's not easy no matter how you do it, but I would just say there's no free lunch with that. And so I think that people might underestimate some of the problems you would still have to solve if you got rid of private insurance companies.
It's always best to go first. So I think one perspective on this is a little bit illuminating. So I think every other developed nation in the world does it better than we do. Our sort of cost per capita is roughly twice the average level in Europe and other developed countries. We're 20% more expensive per person than the runner-up countries. So, and they all achieve universal coverage. And then when you look at the healthcare quality and outcomes metrics, there are exceptions. There's a few areas where we do better, certain cancer care and other things. But for the most part, all these countries that are spending a whole lot less and covering everybody are achieving equivalent and often better outcomes. So my answer to your question is any of the above would be viable improvements in our system. And again, looking across the country, and I'm no expert on other nations' health systems, but I've read enough to know that some are highly privatized, which is much like the building on the ACA model. Some are single payer, some are owned by the government, the British system. Some are government payer, paying private providers in a highly standardized system, and each and every one of them works better than what we have. So my short answer is any of these is a path to doing better than we're doing, which then raises the question of, so what are the trade-offs getting there? And so the incrementalist approach clearly is going to be the easiest. It is not going to be easy. Those of us who were close observers of the enactment of the ACA, it was a friggin' cliffhanger to the end. You may recall Obama writing an executive order basically endorsing the idea that no public money can be used for abortion, yet the one last vote was missing in Florida to get the ACA across the finish line. Oh, and then Henry dies, and the Republican gets elected in Massachusetts anyway. We barely got there enacting the ACA, and you've seen what's happened to the ACA ever since. I think it's going to be hard enough to build on that platform. Having said that, the credible threat of Medicare for all, or whatever you want to call it, is going to be a major lubricant to whatever improvements can be done. Yesterday at the gym, I saw for the first time Stop Medicare for All ad. And so it's starting to be a credible threat. I forgot which company it was, there was a stockholder call with the CEO of one of the major private health insurers, and he mentioned the threat of Medicare for all. And the next day, the stock price took a dive. So it's a credible threat. Having said that, for reasons Kathy outlined, I think there's not a snowball's chance in hell that anything close to what Bernie Sanders is proposing could ever become law. Even if the Senate flips, even if the White House flips, these are some of the most powerful lobbies in the country. There would be roughly 500,000 jobs at stake if we really did get rid of private health insurance companies. Half the population, as I mentioned earlier, has job-based health insurance. And when you ask people if they support Medicare for all, they say yes. If you ask them, do you think you can keep your job-based health insurance, half of them say yes. And those who support Medicare for all are more likely to say that they can keep their current coverage under Medicare for all than people who are against it. So when people start finding out these little details, and one thing's for sure in healthcare is that people are afraid of the unknown. And now that's why public opinion's kind of flipped on the ACA. Now it's the known, or it's unknown. There are really death panels in it, so maybe it'll be okay. And, anyway, it's not going to happen in my view. On the other hand, the more it looks like it could happen, the better off we'll be.
Well, I always judge these programs, again, based on the 4 principles I started with. Universal coverage, price and spending control, standardization of coverage, and a system of social insurance. When you look at our peers internationally and analyze how they've approached it and how they've succeeded where we haven't, they've essentially devised systems providing funding for healthcare that looks something like single payer at different degrees. They either do it through regulation, what's called an all-payer type philosophy, where everyone still participates in the system as private insurance companies or different providers, but they're regulated so in fact they act something like a single payer system. So when we look at the alternatives, number one, can we do it through healthcare regulation? I would say, yeah, we could actually do it through healthcare regulation. The only problem is most healthcare insurance companies and people don't realize how drastic that regulation would be. In fact, most of these insurance companies in other countries that are called private insurance companies act more like contractors for Medicare than they do as independent insurance companies. And in fact, most of them literally do not provide insurance, they're payers. They contract to pay out their funds to the different provider groups that they associate with. So they're not actually even providing insurance. That's done through the social insurance system. So they're what we call in the industry the risk premium, the actual paying for insurance is done by the government. The insurance companies are simply payers. Now, when you look at it, our current employer system is actually a lot like that. 60% of employee coverage is what's called self-insured coverage. The insurance is not provided by the so-called health insurance company. It's provided by the employer. A lot of these employers are a lot bigger than the insurance companies. The company I work for and the plans I help manage, our company was much larger than the insurance companies that actually ran the program. So they're what we call in that day administrative services only. They only administer the funds that the corporations pay for. And that's true with a lot of other countries in the sense with their so-called private insurance companies. But we could achieve it by regulating our insurance companies. So we standardize plans so that we would ensure universal coverage through premium support, a social insurance system, and through negotiation of prices and services. So we could get there in that way. It would operate and look like a single-payer system in many ways. My real question is, well, why not have a single-payer system if you're going to do that? It's almost easier to develop that. The major political issue here is, of course, who gets hurt, who loses. And I think about that a lot. I think about, what about physicians? What do they lose? Actually, very little. For most physicians, it would be a relief to go to a single-payer system. Their major problem would be figuring out what to do with all the extra people in their office, process claims or the myriad of different insurance companies they have to deal with, and the extra time they have to see patients that they weren't able to see because they were calling up for pre-certification and utilization review questions. This is a major problem and a major cost issue we have now. For hospitals, it would be a similar problem. They would have to figure out what to do with all the extras they now have available because they could move out an entire floor of claims processors and managers of the master charge list that they now have to use that creates useless bills for healthcare. So in the healthcare system, that is, people who actually provide healthcare, life would actually get easier in many ways. Obviously, health insurance companies are big losers. Healthcare management and consulting companies, I was part of that group for a good part of my life. They would essentially wither on the vine. There are whole industries of consultants who do nothing but manage claims software and claims adjudication systems for hospitals and providers, and provide through actually fourth-party services for centralized claims processing to deal with the complexity of the system. So we have a system, with a lot of vested interests, but those vested interests are focused on functions that are not central to healthcare. So I think we can get to it through regulation. I think we could actually get it through some of the buy-in programs as long as they include, again, the four principles: universal coverage, price and spending control, standardization of coverage, and a system of social insurance. Simple premium-based insurance, especially as we see it in the employer pieces, is highly progressive. Everyone pays the same premium within our employer. So it doesn't matter whether you're making $1 million or you're mopping the floor and making $25,000, your premium is basically the same. Very few companies, almost none that I know of, pay based on income. So politically, the only way it's really going to change is through a popular movement. It's almost and political leadership. The same kind of leadership that we had in 1965 to pass Medicare. I don't see that around. And where is it? Exactly. But in the 10 years or so that I've been advocating for single payer, I've seen a major change in both the reaction of audiences. I speak to general audiences, and I speak to a lot of physician audiences doing Graham Brown's presentations. I've seen drastic changes in the responses, going from shouting me down to asking questions about how can this happen and what can we see as real progress in the system. So I think there actually are different ways to get to the end. I think there could be an all-payer type way through regulation, even a buy-in way, again, with high regulation, but they all are predicated on the fact that they look like single payer, which is what all the other countries do. They basically formulate their system so that they, again, they have universal coverage, they have some kind of spending and price controls. Most important, they standardize benefits and coverage. The Quality Review Organization for Health Plans reviews over 700 plans each year. 700 plans. The problem you see as an individual physician is you could see a good share, you could see even 100 of those different plans in your practice. Everyone has its own formula. Everyone has its own co-pays and deductibles. This level of complexity is totally unnecessary, as we've seen with Medicare. How many plans are there with standard Medicare? One. It's inadequate. But there's only one Medicare plan, and it is also the standard for Medicare Advantage programs. It's all as well. So in a sense, the Medicare Advantage has been a kind of an experiment in regulating private insurance to kind of equal a public insurance program. So Medicare, our current Medicare is actually an example of how a public is run in parallel with a private insurance system. There are real gaps there also because Medicare obviously is not looking to a lot of private programs by regulation. So again, I think we need to look at how the system operates, not the name of the system. And I think the standard for me is single payer system, the principles of single payer. How we get there can be have various tracks, but it still has to be focused on those four principles. And again, if we look internationally, that has been the success of other countries. They've done it in many different ways, as we all attest to. But they...
Let me move on to the third question. Let me read that out, and Dr. Thayer will start and answer it. Are there characteristics of the proposed approaches that could negatively impact access to health care, including affordability, for women, children, and people of color? Which approaches are more likely to provide the best access and affordability to health care for all of those groups? And for all of us.
Well, the current systems, we already know, has the worst impact on women, children, and people of color. Study after study shows that the system discriminates by socioeconomic group, by color, puts women at a disadvantage in multiple levels. So if we want to move away from those problems with the system, we have to really work hard on creating a new structure. I think, again, what we're primarily talking about here is access to health care. We actually have a good health care system. We shouldn't confuse our health care system with our financing and insurance system. If you have access to health care in the United States, you actually get pretty decent health care. What's really screwed up is basically how we insure it and how we pay for it. So let's focus on that. A lot of the discrimination we're seeing is because of unequal access. Some of it is within the system itself, due to prejudice, etc. But a large part of it is due to unequal access to the system.
I just have a few points to add. I've got to say some Q&A too. First of all, I agree that any of the options are better than the status quo by a long shot. Just a few things to add to that. So under the Affordable Care Act now, thanks to the Supreme Court, expanding eligibility for Medicaid became a state option. States don't have to do it. And when you look at the map of states that have not increased eligibility for Medicaid, it maps almost exactly to percent African American, such as Southern African American, high African American population states that haven't done it. So that my own view, and I believe many others, is that there's a big racist element in that decision. So that was, there's nobody could have anticipated that when the ACA was being debated. It was supposed to be mandatory. So that's one thing. So, if you take an incrementalist approach, that's a tough one to tackle, but I think there's big implications for African Americans and other low-income populations, particularly in the South. Second point is the more you move people kinds of other things about private coverage, and I agree with it being problematic, but that's one where some rights are being protected there. Last thing, and again, the risk of, I think, the more incrementalist approach is if under the ACA and what a lot of states have done to try to expand coverage, they've set the cost issue aside because it's hard. You start driving down prices and costs, that will bring out the opposition. If we continue to expand coverage, if we, for example, increase the subsidies available in the marketplaces, which is one of the ACA, short of the ACA strategies, if we do that without addressing underlying healthcare costs, you haven't addressed any sustainability problem. So I think there's risks in any number of ways across the spectrum, but those are a few that come to mind.
I would just add on the Medicaid expansion issue, and I think the ACA has increased insurance rates or reduced uninsurance for lots of low income and non-Hispanic blacks and Hispanics, so it's had a good effect in further coverage. Expansion would obviously help people that are most likely to be uninsured for. I think Medicaid expansion is, I would guess it's ultimately going to happen everywhere. It's a when, not an if, but I do think it's a very divisive issue, and I think if you're following some of the stuff about work requirements and some of the issues that are playing out in some of the states, and people in the new administration, some that might have said things like they don't really think Medicaid is appropriate for able-bodied adults, and I think there's an issue about Medicaid. It's a political issue that I think complicates the ACA clearly, and is it's going to be something that ultimately probably will not prevail and will be overwhelmed by other opinions, but I think it's something that is open, and it's not really accepted by everyone as a broader sort of social insurance program, and it's thought of by many people as being really appropriate for people that are categorically eligible because of medical problems or babies or whatever. I think one of the interesting things that's going on lately is this effort to expand Medicaid coverage postpartum for 12 months, which I think is an interesting kind of, little wedge issue that, is a very, categorically appealing group. There's a lot of concern about maternal mortality and maternal morbidity, poor health for moms, and, looking at how that issue plays out in states, I think is interesting in light of the sort of politics of Medicaid.
So let's move on to the first question. The speakers have probably said something about this before. Let's see if they have anything to add. The question is, are strengthening the Affordable Care Act and Medicare for All, those are the categories on the far ends, all complementary strategies with strengthening of the ACA laying the groundwork for Medicare for All, perhaps? Or are they contradictory strategies?
Well, I personally think they're complementary. I mean, we have enough stuff to do tomorrow to keep us busy, and we need to hold on to every bit of progress that we've made with the ACA. There's no question about that. We cannot slide backwards from that. From a single payer point of view, Medicare for All point of view, the ACA's most significant accomplishment, besides providing access to health care for literally hundreds of thousands of millions of people, is the fact that it changed attitudes about government responsibility in health care. Before the ACA, less than half of people thought that government had a responsibility and should be involved in health care. After the ACA, that went up to over 70% of people who thought the government should be involved in some way in ensuring health care to its citizens. So that was a very important attitudinal change, in addition to the concrete changes that people now access to health insurance, either through Medicaid, which was in fact the largest part of the program, and the exchanges, which was actually a relatively small part of the program, about 7 million people. So I think each of those things have been progress. I think it helped us move toward solving some of the programs. Their focus has been on access, with a little bit of effort toward reimbursement and price control through some of the reimbursement trials that were part of ACA, the NIPS program, some of the incentive payment systems, which have turned out to be more or less a flop, especially when you consider the overhead cost of actually dealing with the bureaucracy they set in place as well. So, with very small actual savings. So I think, you know, everything that we've done so far has helped. We need to hold on to those and keep moving ahead. I think, again, the major next step, though, is dealing with the price issue. And some states are actually beginning to look at that a little more closely and beginning to negotiate more strongly around prices. So that's the next area, besides access, we have to really deal with is the price of services. The variation in prices that we're seeing. The fact that, you know, according to the latest economic survey, 95% of hospitals are now in a monopoly situation in their communities and really control pricing even against major insurance companies.
Again, the answer has to be both. So ACA passed in 2010. It was the major components implemented at the end of 2013 and almost completely imploded. Likewise, in 1965-66, Medicare implementation was extremely rocky. Medicare Part D implementation was rocky. So, you know, I think to make a major shift to a sort of a pure single-payer approach would probably take 5 years minimum. So how can you not shore up a framework like the ACA while we're waiting? So you have to do both. The New York Times did these quick-run interviews and videos that they posted with a bunch of the candidates asking their positions. They asked Elizabeth Warren, do you prefer the Medicare for all or shoring up the ACA? And she said yes.
And yeah, I agree. I have nothing to add. In the short run, they're completely complementary. Longer run, then
So I have a question for the speakers in the interest of time. Fifth question, maybe have an answer to everybody's satisfaction already. What is the difference in political feasibility of advancing any one or these proposals? Does anybody want to add anything on that? All right, let's go on to the sixth question. What do polls tell us about the public's reaction to each of these approaches? It's been mentioned a little bit. But what are the limitations in the results obtained from the polls? One survey, for instance, indicated that a majority of Americans favor a single-payer approach, such as Medicare for all. On the other hand, another survey concluded that most Americans are happy with their current health care insurance plan and might not want to change. Yet another recent survey found that the majority of Americans are concerned about how much they will pay for their healthcare insurance in the near future. That's sort of been touched on. Anything to add about what Paul said?
Well, I think primarily what the survey shows is how little people really understand the different options that are available out there. Most of these questions really have to have a preamble that kind of explains what it is they're going to be answering. Kind of educates them first and then lets them make a choice based on that information. The other part of about satisfaction with health insurance. And, you know, one of the important factors is that about 80% of the people really don't have a significant financial contact in the commercial population, don't have a significant financial contact with the healthcare system during any year. So the 80-20 years, 20% of them might have $4,000 or $5,000 or more in healthcare costs in any one year. So 80% of the people have no idea how their health insurance is going to work for them, other than the premiums they're actually paying. So they're really talking about what they think about the premium primarily. They're really not talking about healthcare coverage until they get sick. So I think we ought to just survey the sick people who are really in the top 5% or even top 1%. The top 1% would give you about 25% of healthcare costs. Survey those people and ask them what they think about their health insurance and how it's worked for them or hasn't worked for them. So I think surveying itself doesn't really give us a lot of information. It does tell us how people are reacting to very specific questions and where people's awareness is at a point in time. As far as real direction and where we should go, I'm not sure that it gives us good information yet. It may in the future as people become more educated.
So just a few points to add. Lessons from looking at polling over time on these issues, and really interested in this, go to the Kaiser Family Foundation. They do a health tracking poll. It's the best polling out there. So we all have slides in front of us, right? So a few takeaways from that. So we have a slight majority who sort of favor the Medicare for all single payer. It's trended up slowly over the last few years. We're approaching 50-50. And in recent years, support has become, newsflash, has become a lot more polarized. So Democrats are trending more support, Republicans are trending away from support. To me, that suggests that we're looking at a polarized fight, and we see how that's working in a lot of other areas today. It's going the route of climate change. Next point, in general, there's more support for more incrementalist approaches in the polls. Lots of different ways to ask these questions. Public option is better, polls better than Medicare for all, what that's worth. And I agree with Bill on this, but what we see now is a very low information set of opinions. Really sensitive to the way questions are asked, and the good pollsters will say, well, what if, fill in the blank, would that change your view of Medicare for all? And then you throw in things like, what if Medicare for all would lead to more delays in care? 70% drop in support. What if? And we can debate whether it would happen or not, but it's credible, right? What if Medicare for all would threaten the current Medicare system? Huge drop. What if it meant more taxes? That's almost certainly true. Or more deficits. Drop. What if it eliminated private health insurance companies? Even that causes a big drop in support. So I think it's showing some vulnerability. I think if this got to be a serious debate, and hopefully it will, we'll see a battle royale over the messaging. And then lastly, I think more to the point than these sort of random polls where people are answering questions cold is there have been 4 states with serious debates about referenda or potential referenda to move to a state-level single payer. California, Oregon, Colorado, and Vermont. There were public votes in 3 of those, California, Oregon, and Colorado, and they were voted down by basically 3-to-1 margin. 70, 75, 80% voting against, a quarter of people voting for. And that's after this kind of public discourse that will play out. What's telling about that are some of the groups that finance the opponents. Some are expected, businesses, insurers, hospitals, lot of pro-choice groups put money on the table against single payer because they were worried about the issue I raised earlier. In Vermont, it was just withdrawn and essentially it flipped the governor's office because of that's the People's Republic of Vermont. So
yeah, I mean, I think that people are very sticky when it comes to health insurance. They might hate their health insurance, but they're very worried about changing it. But they really want to have the same thing, but cheaper. You know, generally, if you remember the problem Obama had when he accidentally said, if you have your manipulate plan, you keep it, and then he had to walk that back for a very small number of people. And those people had crappy coverage, basically. And just that change that people, you know, had to involuntarily make was, you know, I think everybody remembers the political fallout from that. You see in the individual market, you know, they're either trying to see, well, what would it take to get someone to shop and switch and get a better deal, and it's surprising how sticky people are. So once people start to really realize that they're going to give up the plan that they have and kind of go off into something that's unknown, I think as the other, you know, speakers up here mentioned, that, you know, the support we get. So I think that the idea of, if we ever were going to get somewhere like that, having these intermediate sort of, you know, publicly structured and subsidized plans, you know, like the ACA, like Medicare Advantage, so that people start to get comfortable with what that alternative really looks like, then, you know, I think that's going to be much more likely to get you to a single payer solution than trying to, like some of these states try to do, just, you know, basically, yeah, turn right exactly.
we could set a trombone or something like that.
So I'm going to open up the question from the audience with one that I just thought of. So we've talked about all these bills. We're all experts in healthcare delivery and healthcare insurance coverage. If you could design your own healthcare plan, what are the 2 or 3 characteristics that you think would be the most important to make the healthcare better for the public?
Well, I think I've already gone over my 4 points. Yeah. Well,
let me give you one that occurred to me. Deductibles. There's some evidence that when the deductibles are high, people who actually need to get health services try to avoid getting it. I mean, when we're talking about a deductible of thousands of dollars.
Well, that's a plan design issue. So one of the important things about the current Medicare for All bills is they actually include no co-pays or deductibles. That actually makes the system easier to operate. Nobody has to keep track of co-pays and deductibles. You don't have to have an accounting system for that as far as someone in the office. So co-pays and deductibles were really a kind of a utilization management thing. Most research shows that it's kind of like using a hammer to stop utilization, and it's non-discriminatory. It stops good care as well as bad care. When I was doing my training, especially my MPH and looking at health education, the issues we always spoke about was how to make people compliant and use health care appropriately. So I think the management of utilization of health care is a medical issue, not a financial issue. Because it needs to be managed by the medical system so that we deal with people appropriately as they approach the system. Financial barriers simply actually make the system more expensive to operate, and simply shift the cost from one sector to the other, from the plan to the individual, generally speaking. So they're really not useful. But again, my 4 principles essentially apply. To talk about them more specifically, how do I see single payer looking at it as more of a regional or state initiative. That is, we could set up, change our laws to make it easier for regions or states to adopt a single-payer system or a system that they can operate as an all-payer type system. And we for example, we have a state in Maryland that's already starting has a history of initiatives in single-payer, at least for hospital payment system. But that would allow some experimentation at the regional level. You have to remember that even the Canadian system is a provincial system that has federal oversight and regulation. A lot of, even in Switzerland, it's regulated at the, what they call it, cantons, at the local level. So it would be very important to do that. One of the things to understand is the size of U.S. healthcare. I was looking this up. We're spending something like $3.5 trillion a year. If healthcare were a nation, if U.S. healthcare were a nation, it would be the 5th largest nation in the world in terms of GDP. China, the United States, Japan, Germany, U.S. healthcare. Bigger than Britain. We're talking about the entire economies of these countries, not just their healthcare system. So we're talking about the 5th largest economy in the world when we talk about U.S. healthcare. And we're talking about centralizing this under the Secretary of Health and Human Services, essentially. 1384's regulation and structure department starts with the Secretary shall. And lists all these things the Secretary will do. Well, essentially, that Secretary is going to be controlling $3.5 trillion in healthcare. It's a problem for states too. It's become such a large part of state government that state-sponsored healthcare would usually double or triple their state budgets if it all ran through them. So we have a real governance problem to deal with that we're not talking about enough. When you're talking about nearly 20% of the economy. So, but I do think being able to free up states to deal with more experimentation and single-payer systems by creating much more open waivers around Medicare and Medicaid. And actually, the most important piece of legislation is changing ERISA. ERISA allows all those self-insured companies in all of the states to essentially do whatever they want to do. Not totally, but they are free from state regulation. And that was actually one of the major problems in Vermont, is IBM decided they were going to have to be part of that system. So there are things we could do that would allow more experimentation and operation at the local level, at the state level, or even region level, with an association, say, of several states who wanted to create an all-payer or single-payer system and begin to operate.
I think we mostly covered this. There needs to be a lot less cost sharing. We're way beyond the point where it's useful. And now one can easily be bankrupted by healthcare even when they have good health insurance. It has to be fairer. The financing in particular has to be fairer. It's a terribly regressive system now. So moving more toward a tax finance system. It needs to be dramatically simplified. I think we need to move to keep private health insurance, and I think we will. We need to move toward a more standardized, almost like a commodity. So they're doing a standardized set of services. You can swap out Blue Cross for Aetna, and you never notice the difference. That's their nightmare, but we need to move in that direction. And we need, I think, ultimately, the heavy hand of government regulation and prices. And that would have the secondary benefit of tamping down sort of crazy, keeping up with the Joneses technology competition where every hospital has to have a proton beam machine dollars, and then they have to use it. So that more and more health conditions start having indications that send patients there when it doesn't happen, and often can hurt them. We talk a lot about prices, but the other piece of this is sort of overuse of very expensive technology. We need to pay primary care physicians more, specialists less. There's a whole range of things that need to be done on the price up front. I think everything on my list could be, you can start it, very incremental. You can wipe the slate clean and start up. I don't think that's going to happen. So I think we have to start moving incrementals from those dimensions.
I would just remind everybody that the way that we got to this super high cost sharing was because, before, when plants had a much higher actuarial value, people were spending more and more money. So in a way, this is sort of a response to this escalating cost. So I don't want to totally put lipstick on the pig and just sort of codify the system that we have and reduce people's cost sharing. I mean, I agree with the problems with the high deductible plans, but I also want to make sure that we keep putting pressure on the system to deliver care with huge excess capacity in hospital beds. So even if we regulate prices, I think we have to do more to really encourage people to try to deliver care in a different way, in an radically cheaper way, whether that means making more things available at a prescription, reducing barriers to entry, having more attention to anti-competitive things that that stakeholders in the system do right now. So I don't want to get us in a place where we're not keeping some pressure on the delivery system itself. And if you look at a place like China that has really different kinds of problems than this country does, they're coming up with some pretty interesting solutions that we would want to be perhaps able to take advantage of at some point in this country. So it's everything that's been said, and I would say.
Right, so now we're going to open up questions. We have a microphone stand here, and people line up.
Thank you for a wonderful discussion, everyone. Although I personally am a strong supporter of Medicare for all and HR 1584, I agree with Joe Cantor that despite all the barnstorming and rallies and canvassing that we would do, to use your words, it has a snowball's chance of hell of going anywhere anytime soon, much red. But can I get the panel's reaction to this hybrid that's been going through my mind that I never hear talked about? And that would be to allow Medicare as it exists today to become the baseline insurance for everyone. Allow private insurers to sell Medicare policies so people don't lose their jobs from that standpoint. And not put everything but the kitchen sink in it like 1384 does with long-term care, dental care, et cetera. Maybe to buy into something like that would be better across the board than having a Medicare for all HR 1384 system. Thank you.
I can try to help out there. Folks here, shut up and I'll give it short.
It's very hard to do.
Okay. So I think the idea of universal standardized catastrophic coverage for everybody, maybe with free preventive services like the ACA has, and then it covers everything over 5,000. Simple. You can decide anything you like, and then allow a private market to grow to fill the gap. I think is a very valuable option. I've not seen it. It was actually a term paper I wrote in my health econ class as an undergrad. I think FedEx started as a term paper too, so maybe I'm working on it.
I think if you say Medicare Advantage for all, that is one of the highest sort of bipartisan approval kinds of for them to pay to a percent of their income and have standardized benefits. I mean, I think that that is something that I could imagine us gliding to, and I think the ACA and the popularity of Medicare Advantage would be some of the factors leading to that.
Yeah, I kind of agree with that. One of the biggest selling points for Medicare Advantage programs, though, is standard Medicare. Most people move to Medicare Advantage because of the inadequate coverage of standard Medicare. So at least, they need to compete on equal grounds. That said, the Medicare Advantage programs are actually now beginning to perform at a level pretty close to the cost structure of standard Medicare in terms of the overhead cost structure. So it does show you what can happen when you standardize and regulate private insurance. So I think that's a real area for us to move ahead on. Something that could be done even at the state level is to begin to, first of all, begin to standardize health insurance. That would be a major first step. To come up with 3 or 4 basic plans. We have one human body. We don't need 700 insurance policies for. People keep talking about choice, and they're talking about choosing all these different health insurance programs. I usually call it obfuscation. It's essentially hiding the actuarial value of the insurance from these choices. No one can figure it out. I mean, I'm an epidemiologist / actuary, and I can't figure out most of the benefit structure and cost comparisons of these programs. When you look at other countries, they standardize the programs. When they say standardize, it's not just gold, silver, platinum, type plans. They are exactly the same. Their benefit description is exactly the same. They're totally comparable. So if they have 4 different plans, there are 4 different plans no matter who offers them. They are the same plan. So that would be one step to begin to do that would make purchasing insurance possible. I think the other thing we need to look at is the whole linkage between employment and health insurance. That's another elephant in the room. We are the only developed country in the world where our employees, literal employers, buy our health insurance for us. In other countries, they pay for it, but they don't buy it for us. They don't actually, and in our case, 60% of them are actually insuring us. So I think we need to look at removing that linkage, and one way to do that would be moving a lot of that standardized policies onto an exchange operated by each state.
Accessibility. I'm still a social worker, and I work with a lot of families who have kids on Medicaid. Okay. I have kids, parents who can't access doctors because kids are on Medicaid. I know people on Medicare. I have private insurance for my school, but I have trouble finding people who have providers who have self-insurance. So I'm wondering, how do we get physicians to go to their health office plan? I mean, different plans. How do we get people, medical providers to buy into and participate? That's a really big concern of mine because I'm very grateful to the ACA. In my own personal life, because I have a daughter, a young adult daughter with medical issues, and I'm still working so that she gets to name my plan because I don't want her on Medicaid. And that's a huge concern of mine. But I already see people who have health insurance but can't get the health care they need.
Maybe try to be quick so other people can ask questions. And that's a huge problem. I mean, I think that there have been some empirical studies that have shown an improvement in access for people with Medicaid since the ACA, because more people have Medicaid, and it varies by state. But I mean, it's absolutely a problem, especially with specialists. And part of that is the differential pay. Medicaid pays less than other payers, and I think that's a problem when all payers pay the same. It's you're gonna maybe lose those differentiations, but people are not providers. Some providers are gonna fight very hard because patient cost saving is revenue loss for them. So I don't. It's not a great answer, but it's definitely a huge problem, and it's one of the things that people bring up when they're worried about single payer or no rate setting. Does anybody want to add anything, or should we go?
I actually want to add something short. I forget whether it's Oklahoma or Connecticut. They both have done something with Medicaid. One of them decided to pay Medicare rates for the treatment under Medicaid, and it greatly improved the participation of physicians.
There was a requirement in the ACA that Medicaid pay primary care providers the same payment rates that Medicare does, and it was 2013 to just 2 years. And Kathy was involved in this. I looked at the effect of those payment changes, and the results were
Better access.
it made a big difference, especially in states like New Jersey, which have particularly low Medicaid payment rates. So it's the payment rates. Corollary to the over-migrant school, it's the payment rates.
Many questions. Two groups that you haven't mentioned that I'm curious about in terms of outcomes, cost, price, and especially medications would be the VA, and the other would be are people in Congress. What kind of health care do they get? What are their outcomes? What are the costs?
Well, of course, you'll recall when the ACA was passed, there was a rumor that they were going to require Congress persons to buy their insurance through the exchanges and their staff. Yes, okay. It's an interesting idea, but they're part of. They're using a part of the national system. Their employer is buying their insurance for them, and their employer happens to be the federal government. So I don't see that. What was the other part of the question? Oh, the VA system. Well, even the current Medicare for all legislation kind of holds the VA system apart and talks about dealing with or merging that in the future. My personal feeling is the VA deals with a very special population and provides a large number of unique services that actually are not available in other parts of the healthcare system. And so it really provides a very special piece of a service.
I would just say, some of the bad things that have happened at the VA, like the scandals about maintaining the queue but not really, and those kinds of things will absolutely be raised in any serious discussion about a single payer system, because I think people would abstract from that and say, well, these are the things that go wrong, and you're really dependent on the federal government to provide you access to health care. Might or might not happen the way you want it to.
I'll second that, and I think it's important to observe that there is a faction of our national government
actually from a conservative commentator who asked single-payer supporters of what they would think, how they think that the single-payer system would operate under the current administration, and how successful it would be. You got to remember, you know, even if the Democrats take over both the Senate, the House, and the presidency, it can flip back. We don't know what's going to happen in the future, so there needs to be some kind of sense of continuity with it. So far, you know, we've seen both, at least Medicare survive. Medicaid has taken many hits. The ACA certainly has taken hits, and they tried to abolish it. So the whole concept of governance, I think, has not been dealt with well enough, even by the single-payer group. And that's why I'm more in favor of it being more dispersed with more local, state or regionally based governance.
Does this work? Okay. All right, if I may, just three things. Oklahoma, Libby, and the snowball. Keep me to that. Oklahoma. That was a situation where Oklahoma made their local experiment. Oklahoma had three urban areas, where they kept state payment as single payer. That's it. The other areas they were using as, they gave it away to different insurance companies. After 10 years, they discovered that the state-based payment areas had better access, better participation from people, and better participation from physicians. Kind of important. I don't know if anybody else gets the importance of this, but it does show the effect of a single-payer system in real life. Another thing, Libby, Montana. I don't know if you're aware, but the ACA has a little paragraph written in it for Libby, Montana, because Max Baucus had a very important donor who was going to get very hurt very soon because he was liable for poisoning the entire town of Libby, Montana with arsenic. So Max Baucus rescued him by giving Medicare for all to Libby, Montana, the only area in the country that has it. So one day I got to wondering, how come we don't hear anything about that? So I called Libby, Montana, a couple of their facilities, hospital and caregiving facilities, called their business offices because I'm around, and also my caregiver to family members. I know that's where you call when you want to find anything out. Call the business office. So I called the business offices of these healthcare facilities in Libby, Montana, and I asked them, how are you dealing with this Medicare for people in age groups that aren't over 65? You know, maybe they're younger, or maybe they're, you know, got other issues on top. And they say, why? What's the problem? It's Medicare. Oh, okay. Well, what about enrollment? Wasn't there any problem with enrollment? After all, if they're not 65 yet, wasn't there a problem with enrollment? No, it's Medicare. So I would just put that out. This is exactly how disruptive it would be, how difficult and slow a process it would be to put everybody on Medicare. It wasn't hard for me to get on Medicare, a Social Security number. The process is there already. The structure is there already. We don't have to reinvent the wheel. All you have to do is do it, and it's done. The other thing is the snowball. I want to ask you, the snowball's chance in hell. You know, this is why I follow Dr. Martin Luther King. I'm old enough, in case you didn't realize. Dr. King said, you know, black people deserve to have their rights, but you know what? There isn't a snowball's chance in hell. So just go home, give up. So that's why nobody showed up for civil rights marches, because that's what Dr. King said. Does that make sense? No. What I'm asking now, for Medicare for all, should we just give up? Should I take off my shirt? You want my shirt? Shall I give it to you? What is your take on this? Shall we give up? Or shall we assert ourselves for Medicare for all? Shall we assert ourselves or not? What do you think?
So I think we could all use a snowball right now. So no, don't give up. Of course, don't give up. I still think it's not going to happen, but don't give up.
I think what you've heard tonight is you shouldn't give up, certainly because there are actually a lot of things we can do, even if they're neither McGill, as my boss used to say. We can do many things that would actually greatly improve the system. And they are very realistic steps. And again, if I look at my 4 points, within each of those, we can make real progress. I mean, we can make real progress on price and spending control. Some states are, again, already starting to look at negotiating statewide rates, rate setting, control. That's an area that we really haven't looked at. We can do that. We can certainly begin to standardize coverage. You know, that's a real possibility. And we can certainly begin to increase social insurance even by premium support programs, which are started in the Affordable Care Act. So even within those segments, which are actually a part of the single-tier structure, you can start moving and closing those gaps.
I'd just say, you know, arguably there's a crisis in healthcare right now. It's a top issue for most voters, and there's multiple calls to action advocating all different solutions, including greatly expanded roles for government, and policymakers accept responsibility and say the status quo is no longer good. So this is part of that. Who knows what will happen at the end of the political process and lots of stakeholders. But this is completely part of what we need to be doing right now, because this has reached a pain point for people. So yes, you should keep your shirt on.
So just one more thing to add. One thing that I still go with my statement that, you know, keep at it. You should keep at it. But I'm really wary of this becoming such a deep wedge issue when it doesn't really have to. Because I think one thing, you know, we come from different perspectives, but what you heard was a list of probably 10 things that can be done incrementally that would move us in the right direction. We might end up all the way to the goal of single payer, we might not. But if we get stuck on repeal of Obamacare versus Medicare for all, I think that could impede progress. So I would say it's important to have some flexibility, you know, advocate, but also be flexible.
This is kind of a joke, actually. It used to be when I was consulting. Our saying was, we're all going to get to single payer eventually, except it's going to be called United Aetna CVS WellPoint Humana Anthem. That's the name of the National Healthcare Program. I do think we have a real issue, though, that we have to deal with the centralization of power and control in corporate medicine. has to be dealt with. And we certainly have to deal with it with the conglomeration of hospital groups and their purchasing physician practices and creating community monopoly systems. So that's another area we should have pretty immediate action.
I guess I personally feel like there's, two important issues, one of which we've been talking directly about today, which is expanding health insurance and access to medical care. And then there's one that's kind of lurking on the side that we've been obliquely talking about, which is winning the White House, winning the Senate. Some of the discussion of the polls and the surveys have indirectly touched on that. I personally feel like our chances of winning back the White House and the Senate are much poorer if we run on single payer. It may mobilize part of the base, but we would lose more people who are worried about their employer health insurance that they want to hold on to or pay higher taxes, even if they are misperceiving the relevant benefit. But I'm curious, there's a bunch of candidates who are supporting Medicare buy-in. And I'm wondering if you could reflect on the polls and also on the experience on the public option on how we could mobilize support for that, who stands to win and lose, which are likely to be perhaps persuadable, and which ones do we have to worry about in 2020 election if we're going to propose that as a Democratic platform.
Just say two quick things. I think if you talk to Republican strategists, they will say Medicare for all is the greatest gift that the Democrats can give them in the election, and that health care is a Democratic advantage issue until it becomes about single payer. That's one thing people say. As far as the polls go, I think when it's an and not an or, when there's a public option and you don't have to change what you have, there's way more support. So I think that middle ground is I think
Give yourself give numbers if you can. So the latest poll, Medicare for all polls at 56% positive. Optional Medicare for all polls at 74% positive. Very buying options framed in different ways about the same. So you get about 3/4 support for the and just over half support for the or. And then you start getting into the what if it means this, that, and the other thing that goes way down, more taxes, less choice, whatever. So it has legs, I think.
No, I agree. I think I want to add one other political and social area that really doesn't get discussed outside of the medical community. And it's the whole issue of physician and provider burnout. Almost every time I open a journal now, I read about physician burnout. I have a daughter who's a physician also, and she talks constantly about her peers and the physician. One of the things we have to do, and we have to do fairly quickly, is make the system more friendly to providers, make it a place where they can actually live and work. And a major part of their complaint is the complexity of our current system. It takes away autonomy, it takes away their role as in decision-making with their patients, it interferes too much, and it engenders a sense of helplessness, which is a prime cause of burnout. Lloyd's nodding his head. And, we also have seen that as retired physicians. So I think, part of what we need to do quickly is to begin to simplify the complex structure. And we can do that probably legislatively, again, by standardizing plans. Actually begin to make limitations on things like utilization review recertification, which are hallowed in the insurance industry, but when you look at studies, are not that effective. Really not worth the money if you want to look at it that way. So there's, again, I think there is another important step that we can make to make this, making it so 40% of physicians don't feel like they are near burnout, to really improve productivity and patient and providers' satisfaction with the system.
Thank you for being here. Thank you for being here. AI, we haven't talked about that. Retail workers in America are being displaced by it. They are the largest group of people working in America today. And when we look ahead, as we've intended to want to do tonight, AI is going to have an even larger effect on the health industry. Could you speak to that for us?
I think that's right, and I think there are a lot of good opportunities for better clinical care coming from AI, and there are a lot of opportunities for cost saving, and I think that the thing we haven't been talking about tonight is that so much of the expense of the healthcare industry is labor, and I think that almost everything that we've been talking about is going to have significant implications for the workforce, and so is technological change.
Yeah, I agree. I think these kinds of technological advancements are going to help a great deal. They may complicate things, but I'm thinking back to my early days with Internist 1 and Internist 2. Some of these early programs that ran on mainframe computers, which were not quite as powerful as my cell phone. But we are approaching an era where these kinds of artificial intelligence aids will help a great deal in areas like differential diagnosis and pinpointing therapies for more customized kinds of service. But again, those are more healthcare delivery issues in the healthcare system itself. I guess the only thing we want to be aware of when we talk about the insurance and the payment structure is that they don't hinder these kinds of developments, that they actually support them and make sure that there's rational payment systems for them as well. We're seeing major advances in telemedicine, something that's been nascent for years, but is really actually starting to develop now. For the first time, I got a message from my own internist who said, you can now contact me through video conferencing for a video consultation. And we're seeing those kinds of things more and more.
But where do you see the hundreds of thousands of people that are being displaced by AI getting their health insurance?
Well, that's a big issue. That's a social issue, and it's also an issue, that we have to deal with even with the single-payer initiative. My organization, Physicians for a National Health Program, actually estimates closer to 1 million people work through a simplification that will happen with the single-payer system. And it actually is going to be larger than that, I think. They're not even counting all the auxiliary consultation companies that I used to work with, who are kind of hangers-on and become necessary because of the complexity of our current system. So we basically have a payment system that's eating healthcare right now, quite literally. The expenses of our payment system are very underestimated by most studies. Most of the single-payer studies that you see, they simply look mostly at health insurance overhead, which is only a small portion of it. When you get inside of the system and see how it operates, you see how that complexity pushes into hospitals and providers' services and creates a huge amount of overhead in the system. Again, PMHP, our estimate is closer to somewhere between 25 and 33% overhead in our American system, which is several times what other countries are spending in overhead.
So please thank our panelists. Before we go, I had one ask of all of you, and it's not about health care on the federal level, it's about health care on the New Jersey level. There is a bill that's passed the New Jersey Assembly and has come out of committee in the Senate that seeks to establish a New Jersey-run health care exchange for the Affordable Care Act. It's Senate Bill 3807. It's being prevented from coming to a vote in the Senate by Senate President Stephen Sweeney. What I would ask you, why? It's not clear why. I think he's just against putting it to a vote. I don't know whether it would fail or not, but he doesn't want to put it to a vote. What I'm asking you is to call and email your state senator, and if you agree with that idea, to urge him to put pressure on Stephen Sweeney, if that's possible, and if it does come up for a vote, to vote in favor. Kevin?
Just quickly, for those of us living in Highland Park and McCutcheon, that's Patrick Digan, D-I-E-G-N-A-N. You can find his name on the state legislative website, and you can send him an email through that system. You can do the same for Stephen Sweeney.
Who your state senator is, you can find that easily on the state legislative website. There's a list on the left-hand side. One of them says, find your senator. Easy enough to do. Just follow the rules. Thank you all.